Uh, Good evening, one and all. I welcome you for the third session of the voice module. Today we have four eminent laryngologists who would be sharing their vast experience in their respective topics. The first speaker for today is Dr. Marina Madbaki. She's a course director for the Laryngology Fellowship Program in Malaysia. Professor Dr. Marina is a senior consultant otolaryngologist, head and neck surgery in Malaysia, subspecialized in the field of laryngology. She was awarded a PhD in the Laryngology of University College London in November 2014 for the topic of Laryngeal Re-Innervation. She worked with distinguished laryngologists Professor Martin, Dr. John Rubin, and Dr. Guri Sandhu. Her special interest is in laryngotracheal stenosis, laryngeal paralysis, voice disorders, phonosurgery, sleep apnea. She received several referrals from all over the Malaysia. She works closely with all the neurologists, endocrinologists in providing laryngeal electromyography test services and actively managing recurrent laryngeal nerve injuries with endocrinologists in thyroid cancer cases. She has been invited to talk on laryngology topics in national as well as international conferences. She has published 67 papers in WS, Scopus, and Index journals. Without wasting much time, I would like to invite Dr. Marina to speak on the topic diagnosis, management of unilateral vocal cord palsy, re-innervation, and injection in laryngoplasty. Dr. Marina, over to you.
Hello, everyone. Thank you so much, Dr. Mada, for the very kind introduction. First of all, I would like to thank Dr. Sachin Gandhi and team for giving me the opportunity to share some experience and knowledge on this topic. I'm going to share my screen now. So the topic that I'm going to speak today is on diagnosis and management of unilateral vocal fold paralysis. And I'm going to focus on laryngeal re-innervation and injection laryngoplasty. This is Faculty of Medicine, University Kebangsaan Malaysia in Kuala Lumpur. So the content of the lecture would include a brief introduction on treatment algorithm for unilateral vocal fold paralysis, and followed by specific topic on non-selective laryngeal re-innervation, injection laryngoplasty, and conclusion. Before that, I would show some case demonstration. The treatment of unilateral vocal fold paralysis is no more watch and wait for 6 months. There is a paradigm shift in which the current recommendation is to treat unilateral vocal fold paralysis actively, especially in those patients who present with acute unilateral vocal fold paralysis. This is because the earlier intervention we give, the better voice outcomes will be. And that would also prevent muscle tension dysphonia and would reduce the chance that the patient need permanent surgical treatment. And you can also, with providing early intervention, you can send the patient home without having nasogastric feeding in those patients who have aspirations. So the surgical treatment for unilateral vocal fold paralysis, the main aim is to allow contact, firm contact between the two vocal folds, between the normal one and the paralyzed one during phonation. And the aim also to rehabilitate swallowing, to minimize or alleviate aspiration. So these are the surgical options that been proposed in the literature. Number one is injection laryngoplasty, which can be temporary or long-term, depending on the material that you inject to the paraglottic space. And the technique of injection can be done either under local anesthesia, percutaneously, transthyroid, transcricoid, or transthyroid approach. For another surgical option is open thyroplasty, or also known as type 1 thyroplasty, to medialize the vocal fold, paralyzed vocal fold, and with or without arytenoid adduction, as shown in this picture. Type 1 thyroplasty using Gore-Tex implant or PTFE. The other surgical option is laryngeal re-innervation, which will be the topic today. like shown in this picture. So for these the last three options are considered as permanent surgical treatment, and which commonly we offer this in chronic paralysis. However, for laryngeal re-innervation, it is quite robust because we can offer it during acute paralysis, even on table when the nerve is transected. Or we can do it in chronic phase if the patient is referred late, or when you are waiting whether the nerve function would recover or not, in cases you are not sure the nerve status of the patient. And also you can do during the subacute phase, like 6 months, within 6 months after injury, if the nerve is confirmed to be transected and you are not there during the transection and the case was referred to you late. And during these phases as well, you can do temporary injection laryngoplasty, which I'm going to show in other slides later on. Now we're going to talk on laryngeal re-innervation. What is it? What is the principle of laryngeal re-innervation? So the aim when you perform this surgery is to restore laryngeal function. How can we do it? Is by regenerating new motor axons from a donor nerve, and this new motor axon will grow and eventually re-innervate the paralyzed intrinsic laryngeal muscles. So this is diagram shows the principle of technique of surgery, which the re-innervation can occur by doing neurorrhaphy between two nerves, either the same nerve which is transected, or you borrow another nerve to make the new axon grow into the paralyzed, the injured nerve. The other way is autotransplantation. Whenever you have the proximal and distal part and the gap is too far, then you need a cable graft, a cable nerve to bridge the growth of axon. Another way of doing a re-innervation is by directly implant the nerve on the muscle, which the new axon will sprout into the paralyzed muscle and re-innervate it. Or you can use nerve with island of muscle that is supplied by the nerve and implant on the paralyzed nerve. And you also can use a conduit to make sure that the nerve growth is more effective and prevent sprouting outside of the area. And here, apart from the surgical technique, the principle how you do the repair, the other classification that we need to remember about laryngeal re-innervation is there are two main types, which is one is non-selective, the other one is selective laryngeal re-innervation. What do we mean by non-selective? Non-selective is commonly offered for unilateral vocal fold paralysis when airway is not the problem, but the voice is the issue. The voice is breathy. So in this surgery, you wouldn't get the mobility, but you would get synkinesis because you are not targeting the muscle. You are using the whole trunk of the nerve, and the both abductor and adductor axons are like there would be aberrant re-innervation into the abductor and adductor muscles. And however, it would re-establish tone and bulk. I'm going to explain more to this. So like, for example, in this patient who have unilateral vocal fold paralysis, so you can see that there is bowing and there is a gap, phonatory gap. So airway is not the problem, but gap is the problem. So phonatory gap. So by getting a donor nerve, repair it into the injured recurrent laryngeal nerve, you are re-innervate the paralyzed vocal cord. So I just want to say a little bit of principle here. In one nerve, the recurrent laryngeal nerve, it has both axons, abductor and adductor axons. So if you repair a donor nerve into the main trunk of recurrent laryngeal nerve, both abductor and adductor axons which grow from the new nerve, from the donor nerve, wouldn't be able to choose which muscle to go. So therefore, there will be aberrant re-innervation. Because of aberrant re-innervation, there would be mobility, but the tone and bulk will be there. So hence, as shown in this photo, before re-innervation, this is taken from paper Wong et al. The vocal cord, paralyzed vocal cord is in a cadaveric position or lateral position with bowing, severe bowing, and there's big phonatory gap. After non-selective re-innervation, there is no mobility, but the function, the position of the vocal fold from lateral become median or paramedian without bowing, and there's tone and bulk, in which when the patient phonate, there is closure of phonatory gap and the patient's voice will be strong. The other type of re-innervation is selective. This is mainly for bilateral vocal fold paralysis, when the main problem is airway, because inability of the vocal folds to abduct. So in this surgery, the main aim to re-establish the abduction. How can we do that? Okay, this is a video showing a patient with bilateral abductor paralysis. Voice is not the issue, but airway is the issue. The patient can't abduct the vocal fold. So by doing this surgery, non-selective re-innervation, which using a frank nerve and target the re-innervation to the posterior cricothyroid muscle to gain the abduction, so that whenever the patient breathes, the diaphragm move for respiration, the PCA will be activated and there will be abduction as well. So selective re-innervation is not the topic of lecture today. Now I'm going to focus on non-selective, which is the surgical treatment for unilateral vocal fold paralysis. Remember, there wouldn't be mobility, but there would be return of bulk and improve the position of the vocal fold to close the phonatory gap during phonation. So these are the surgical techniques that have been proposed in the literature. The common one that been used is neurography using ansa cervicalis to recurrent laryngeal nerve, and the other one is direct end-to-end neurography, the proximal and distal part of the recurrent laryngeal nerve. And ansa cervicalis is the recommended nerve because it's very near to the recurrent laryngeal nerve. And it is also a motor nerve. Studies been done in animals which shows that during phonation, there will be firing and activation of the ansa cervicalis. So when we want to identify the ansa cervicalis, the landmark is the omohyoid. We look for the main branch of the ansa cervicalis around underneath the omohyoid, or it could be lower down without the main branch, but you can use the stenohyoid branch or stenothyroid branch. This is recommended because the caliber is almost similar to recurrent laryngeal nerve, and it contains a lot of motor axons for the nerve, for the re-innervation. And to find the recurrent laryngeal nerve in cases post-thyroidectomy, where the tracheoesophageal groove is scarred because of the previous surgery, you can identify the nerve by doing intralaryngeal dissection, by cutting the inferior part of the constrictor muscle overlying the thyroid cartilage, do dissection, and you find the nerve underneath the piriform fossa. So whenever we have identified both nerve, the recurrent laryngeal nerve and the ansa cervicalis, you need these instruments to repair both nerve. Between the main trunk of recurrent laryngeal nerve that is entering the larynx and the distal part of the ansa cervicalis, which you have transected from the strap muscle. The instruments that you need is microscope, microvascular instrument, which is compatible to Ethylon 9O, and you need a glue to enhance the repair. So when you are doing this repair, it is very important to make sure that the suture that you make is between the epineurium to epidural without stabbing through the fascicles, because if you stab through the fascicles, it will impede the growth of the axons. This picture shows delayed non-selective re-innervation. What do I mean by delayed? The re-innervation ulcer cervicalis to recurrent laryngeal nerve was done months after thyroidectomy, 1 year and above, or like, you know, not on table. So the recurrent laryngeal nerve was identified intralaryngally. Let me orientate you in this picture. This is the superior part of the patient, inferior part, lateral part of the patient. That is the lateral border of the thyroid cartilage, which retracted by this retractor. And the superior constrictor muscle already reflected laterally, and the recurrent laryngeal nerve was found here intralaryngally. So it is beneath the piriform fossa and overlying the posterior arytenoid muscle. And this is the lateral part, the ulcer cervicalis, which is found earlier, was brought over to meet the recurrent laryngeal nerve, and the suturing is done. 3 sutures are enough, and then it is enhanced with a tissue glue or fibrin glue. So this is a delayed re-innervation. We also can perform this ulcer cervicalis to recurrent laryngeal nerve acutely on table when the nerve is transected. We have published this paper sharing our experience in doing primary non-selective re-innervation, in which the patient's voice was totally normal. Before surgery, during the thyroidectomy, the nerve was transected, accidentally transected, or it was transected because of tumor. So this picture shows the on-table re-innervation. As you can see, there is no more thyroid gland. The strap muscles are also transected together with the tumor. And I did the ulcer cervicalis to recurrent laryngeal nerve repair on table. And in this surgery, for the nerve to regenerate, to grow, it takes about 1 millimeter a day. So then you will need about 4 to 6 months to observe the return of bulk, the improved position of the paralyzed vocal fold. Hence, temporary injection laryngoplasty is recommended to help the patient's voice while waiting for the re-innervation, while waiting for the effect of re-innervation. So in our center, we use Juvidum, which is hyaluronic acid. I think in the other parts of, in other centers, they may use other kind of hyaluronic acid like Restylane, Surgidem, and so on. Laryngeal EMG is required in performing a re-innervation, because you want, number 1, you want to confirm the neuropathy. Number 2, you want to compare to see the progress of the re-innervation, to observe the success of the re-innervation. So in this patient, I did a baseline laryngeal EMG. This patient had transection of the nerve, and re-innervation was done on table, primary intervention. So 1 month after the transection and after the re-innervation with injection laryngoplasty, there is hardly any recruitment of motor unit action potential. At 6 months, there is new re-innervation recruitment of nerve or motor unit action potential can be seen. At 12 months, there is intense recruitment of motor unit on phonation, and it is comparable to the opposite side, which is the normal side. You can visit my YouTube channel to see the technique of surgery ulcer cervicalis to recurrent laryngeal nerve repair. A little bit on injection laryngoplasty. Injection laryngoplasty is a procedure whereby they aim to augment the paralyzed vocal fold, to increase the bulk and medialize it. It can be done either transorally under general anesthesia or transcutaneously under local anesthesia. And the biomaterials, you can use fat or bovine gelatin, hyaluronic acid, or calcium hydroxyapatite. And the clinical effectiveness generally is about 4 to 6 months. Of course, some biomaterials like fat, if you prepare it properly, like adding PRP or using, what do you call that? Sorry, the thing didn't get to me. So you have to prepare it properly, or if you use a calcium hydroxyapatite, this is considered a long-term injectate. It can last up to 1 year or more. However, in a re-innervation, we choose to inject a short-term because we want the temporary effect while waiting for the re-innervation. Right, in a systematic review on early injection laryngoplasty, early injection laryngoplasty may reduce the risk of needing type 1 thyroplasty. So the earlier you do, the less chance the patient have to undergo a second procedure, which is a permanent procedure or like a type 1 thyroplasty. And the injection is done lateral to the vocal ligament, lateral at the level of vocal fold process in the paraglottic space, like shown in this picture as well on a coronal view. And this is the two materials that been used in my center. For short term, we use hyaluronic acid. For long term, we use calcium hydroxyapatite. So the long term we use when, I give an example, cases where the nerve is accidentally transected or transected because of tumor and re-innervation is not feasible. For example, there is tumor left behind at the area where we want to do re-innervation, or the donor nerve is not present because it was removed together with tumor. So instead of injecting hyaluronic acid, we inject calcium, which it can last longer, and later on we can think of doing type 1 thyroplasty if the patient's voice deteriorate after 1 year. This picture shows surgical approach for percutaneous local anesthesia, transthyroid, or transcricothyroid. There is a paper showing, recommending a type of needle or bending needle to ease the injection transthyroid by bending at 45 degree at the hub and 45 degree 1 centimeter from the tip of the needle. By doing this double bend needle and pierce the needle through the transthyroid, you can maneuver the needle to the side that you want, either anterior or posterior, easily. We have published our results on early transthyroid injection laryngoplasty using a double band needle. We bend it like how proposed by the paper by the author Akka et al. And it shows that the injection under local anesthesia is safe and effective. You can read this paper which is published recently. So just to show this technique, after intratracheal anesthesia is given, the larynx is anesthetized, and this double band needle is pierced through the superior thyroid notch, and we will observe the tip of the needle enter the larynx
laryngeal surface of the epiglottis
at the petiole of the epiglottis.
Oh, escape, Fana.
Okay, can you see that? That is the needle, all right? And the needle, after it pierces through the petiole, you can easily aim it to the side that you want to do the injection, like in this case, the left side of the vocal fold, like so. Lateral to the vocal ligament and at the level of vocal process, and to inject the augmented overcorrected 10 to 20%. So this is under local anesthesia. However, in cases that we combine re-innervation and injection laryngoplasty, we do it transorally. And it is recommended that the tube is removed, like, when you do thyroidectomy, you do the injection last. After thyroidectomy and the re-innervation on table, you do it last. remove the ET tube and do jet ventilation. So this video shows a patient after thyroidectomy, and we have done a re-innervation at the same setting. The NIM tube was removed and then jet ventilation was provided, so that after that we inject the patient at the site of palsy, at the site where the nerve is transected. And we use this, and this is how we prepare the butterfly needle, which is type of needle that we use to inject the vocal fold. You can see this on my YouTube channel. Okay, so here I just want to show you where we inject the material. So this is just for demonstration purposes. This is a patient whom I treated, a teenager who had tumor in the paraglottic space. You can see that the vocal fold is medialized on the side where the tumor is. And this is the false cord being removed, and you can see the tumor in the paraglottic space. And after I have removed that, this is the paraglottic space. So I want to show this to demonstrate to you where we inject the biomaterial in it, when we perform injection laryngoplasty. So this is a vocal ligament, and next to it is thyroarytenoid muscle, and this is the space in the paraglottic space. That is the vocal process of the arytenoid. So the needle has to go here to fill up the paraglottic space, augment the vocal fold, and medialize it. This shows injection laryngoplasty transoral using modified butterfly needle. The patient has no tube because the patient was given jet ventilation or tubeless ventilation. Positive pressure was given supraglottic pressure. And you augment it until it is 10 to 20% overcorrection. However, and after that, you don't intubate. Instead, request the anesthetist to put laryngeal mask so that the tube wouldn't be squeezing the gel out, yeah, at the glottic region. So just show two case demonstration. A young female who had papillary thyroid carcinoma. The recurrent angina was accidentally transected during the surgery. So a primary non-selective renovation ulcer cervicalis 2 recurrent angina was performed, and transoral injection laryngoplasty was performed as well. And this is the patient's voice 2 weeks after the re-innervation and injection laryngoplasty following the thyroidectomy on table surgery.
Okay, boleh mula. Semasa saya masih kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar. Abang dan adik saya.
So the voice is good, okay, although the maximum phonation time is not as good. The patient can sustain up to 5 seconds. And this is the so you can see that the right side is the injected part of the vocal fold. And this is at 1 month of the surgery.
Semasa saya masih kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar. Abang dan adik saya tinggal di bandar.
You can hear that the voice now becomes stronger. And this is at 12 months of the surgery.
Masih kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan emak.
The voice become better and better, stronger and stronger. And this is the larynx. So she has symmetrical mucosal wave with complete closure. And this is the glottal cycle of the patient. Case number 2. So the first case that I demonstrated is on-table primary re-innervation together with injection laryngoplasty. The second case, a delayed case, which the case was referred 1 year after thyroidectomy. The patient has hoarseness and breathy voice. And this is the larynx. You can see that there's huge phonatory gap. the vocal cord is in lateral position with severe arytenoid, anteromedial prolapse of the arytenoid. And this is the patient's voice before re-innervation.
Ayah dan mak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan mak. Setiap minggu.
So the voice is breathy. And this is 3 months after re-innervation.
Semasa saya kecil, saya tinggal di kampung bersama nenek.
The voice improved, but then still breathy, and the effect of the injection of the hyaluronic acid is wearing off at 3 months. And this is his voice at 4 months after re-innervation.
Semasa saya kecil, saya tinggal di kampung bersama nenek, ayah dan mak tinggal di bandar.
So this shows that now the re-innervation is taking its effect, and the patient's voice becomes stronger after that. And this is at 6 months after re-innervation.
Semasa saya kecil, saya tinggal di kampung bersama nenek.
And this patient's voice is stable and continue to improve. And this is the stroboscopy montage of the glottal cycle. So in conclusion, non-selective re-innervation is an option for unilateral vocal fold paralysis, which can be done in acute, on table, subacute, or in chronic phase of recurrent laryngeal nerve injury. And successful surgery will result in re-innervation of the paralyzed muscle, but with synkinesis, without movement of the vocal cord. It provides bulk, resting tone, and favorable position for phonation. In this surgery, all muscles, the TA, LCA, interarytenoid, and PCA will be re-innervated. Hence, the arytenoid reposition will occur naturally in successful cases. Temporary injection laryngoplasty is recommended while waiting for the re-innervation to kick in. With that, thank you so much for your kind attention.
Thank you, ma'am, for the wonderful lecture and informative talk about the re-innervation, which is a very quite rare topic. We'll take questions at the end of all the 4 lectures are done. Moving on to the next one. The next one we have Dr. Vyas Prasad. Dr. Vyas Prasad is an otorhinolaryngologist consultant from Singapore. He specialized in voice and swallowing disorders as well as head and neck surgery, performing minimal invasive surgeries utilizing lasers. He is also a good surgeon in open oncological procedures for cancers of head and neck, thyroid, and salivary glands. So we have Dr. Vyas. He'll be talking about MTD, muscle tension dysphonia, to operate or not to operate. We'll be playing a short video with important points of Dr. Vyas Prasad from Singapore.
Sir, you are muted.
Yeah, we just have to play the video of Dr. Vyas Prasad with his talk about muscle tension dysphonia.
Good afternoon from Singapore, and thank you, Sachin, for this invitation on your seminar of Laryngology Back to Basics. My topic is muscle tension dysphonia, to operate or not to operate. Morrison et al. In 1983 first described the phenomenon and condition of muscle tension dysphonia, and effectively it is a form of voice disturbance where there's excessive tension of the paralaryngeal muscles, as well as the tension of the suprahyoid muscles. Muscle tension dysphonia is the preferred diagnostic label, although there are others such as functional or non-organic dysphonia. In essence, where there is an absence of any structural, neurological, or laryngeal abnormality, this is considered as a primary muscle tension dysphonia. And in primary muscle tension dysphonia, as we are very aware, it is multifactorial, and it's usually due to the improper use of muscles of the larynx whilst in phonation. And secondary muscle tension dysphonia is often compensatory from other pathologies that affect the larynx. So what are the findings? Well, the voice is suboptimal, and there is definitely a reduction in the quality of the voice, with roughness, breathiness, and strain being predominantly the issues over here. Constriction is usually at the glottal and supraglottal level, and it can be both anteroposteriorly affected as well as laterally. There's elevation of the larynx, tenderness around the muscles, underneath the neck, the paralaryngeal muscles, increased suprahyoid muscle tension. And interestingly enough, this particular condition makes up about 40% of clinic presentations. What happens if this is not treated? Well, it lasts for a while and results in phonotraumatic lesions such as nodules, polyps, and chronic laryngitis. Glottal insufficiency has been described, usually posteriorly, and we don't really know whether this is a consequence of the condition or a cause. So what are the treatment options? Voice therapy is the gold standard, but not everyone responds, and in a study in 1991 by Kaufman et al., there was a 29% rate of lack of response. Why is that? Well, first and foremost, the condition is multifactorial, it's poorly understood. There's a lack of diagnostic rigor, a lack of specificity of laryngeal findings, and it's similar to tremor and spasm. Other therapies, including laryngeal manipulation, physical therapy, such as improving the range of movement of the neck and shoulder, in conjunction with voice therapy, have been shown to help. However, the evidence is insufficient to state whether or not these other forms of treatment would be equally as good or synergistic with voice therapy alone. Transcutaneous electrical nerve stimulation, elastic taping have also been described with similar issues about evidence. Telehealth is more in vogue, and patients are now constantly on the move with their smartphones, etc. And so exercise videos can help certain groups of patients, and it improves the frequency of practice of voice therapy and also their motivation. Medical therapies, including false cord Botox injection, have been described in certain recalcitrant cases, as has injection to the recurrent laryngeal nerve of lignocaine or topical application in the larynx. Subjective improvements of symptoms have been shown, although the study is extremely small and the follow-up is also very short. Surgical techniques, and this is coming down right now to the crux of the talk, to operate or not to. Well, we've already stated that we don't really know why people get muscle tension dysphonia. And so therefore, are we really treating the cause, or are we limiting the sequelae, or are we trying to improve certain aspects of the condition, similar to spasmodic dysphonia or tremor? So false vocal fold ablation has been described because of the hypertonicity of the vocal folds, and there have been certain studies that have shown improvement, as has reduction of the lateralization of the vocal fold. So this is for refractory muscle tension dysphonia, where there's supraglottic hyperfunction. Perhaps this is a last resort. There are plenty of papers on this particular study, but very, very few systematic reviews. And there are very little specifics with a paucity of high-quality studies, and the reliability of data is actually an issue. What about outcome measures in these patients? Well, they're inconsistent across a lot of papers, and as I mentioned before, the paucity of evidence in the literature makes the management of this condition all the more difficult. There are also many studies which lack a control group, and the longitudinal follow-up, as I mentioned before, is lacking. So in conclusion, when to operate or when not to is a tricky question, because often, being the gold standard, voice therapy should be advocated, and surgery only in the most recalcitrant cases where you've come to the end of your tether and there's nothing left to offer the patient. In essence, muscle tension dysphonia is a poorly understood entity despite its high incidence, and conservative therapy is the mainstay. Medical and surgical management in selective cases can be advocated. Thank you.
Thank you, Dr. Vyas, for sharing your vast experience and information about muscle tension dysphonia. The next talk would be by Dr. Sachin Gandhi, sir. Sachin Gandhi, sir, is the director of the Voice Clinic, Dinath Mangeshkar Hospital, founder president of Laryngology Voice Association and Asia Pacific Laryngology Association. He has numerous publications in Indian and international index journals. He was invited guest faculty at many international conferences. The topic for today is about the role of laser in spasmodic dysphonia. I request Sachin Kanti sir to go ahead with this talk.
One sec. Okay. Good afternoon, everybody. The role of lasers in managing case of spasmodic dysphonia. As we know, it's very challenging condition to treat. Spasmodic dysphonias, just for a second, would comprise of various types. The adductor, abductor, mixed type of spasmodic dysphonia. But the most common of all of is adductor spasmodic dysphonia. And it consists of around 90% cases of spasmodic dysphonia. What happens? Excessive adduction or adductor spasms during phonation. We hear irregularly interrupted, strangled, strained voice with vocal breaks. You can see in this clip now. So we see strangled and strained voice with vocal breaks. The most commonly involved muscle is, of course, thyroid, but can also affect other adductors like lateral cricoarytenoid or interarytenoid muscle. Diagnosis is generally clinical. On video laryngoscopy, there are no specific features of this condition, but you can see associated structural pathologies. Because of hyperadduction, there could be phonotraumatic lesions like polyps, nodules, contact granuloma. There could be associated compensatory mechanism with supraglottic hyperfunction, false chord edema, false chord hyperadduction, as well as tremors in the larynx, laryngeal tremors, and laryngopharyngeal reflux. So we'll see this clip. So these tremors, you see the tremors. See, and the hyperadduction is seen for both true as well as false vocal cords. So these are compensatory mechanisms for hyperadduction of the vocal cords, but not specific features as this condition goes. What could be the treatment? Treatment should aim at improving both sound production and voice quality, but without interfering with the sphincter function of the larynx, that is, without giving any aspiration, and it should be a long-lasting relief. Role of voice therapy. Voice therapy is absolutely not been reported to be helpful for this particular pathology, but it may help for compensatory mechanisms like hyperadduction of the false vocal cords or compensatory phonotraumatic lesions like contact granulomas, polyps, nodules. The time and tested method of Botox injection in the thyroid muscle, which gives chemo denervation of the thyroid muscle. The results are substantial, but there are variable relief of symptoms, but very few or absolutely no side effects with this method. But it lasts for a limited time, maybe several weeks to 6 to 9 months. The effect also gradually subsides with repeated injections because of development of antibodies to this protein or to this molecule. The role of surgery, it targets the end organs, either the recurrent nerve, its branches, or thyroarytenoid muscle itself. Relaxing type of laryngeal framework surgery, that is type 2 thyroplasty, have been described and followed in many centers. Another approach, transcervical or transoral laser surgery, which would target the muscles and the nerves. What the transoral laser would do, instead of chemo denervation, it will give thermal denervation. So basically what we want is denervation, and we get it through laser surgery because of the thermal damage. We can cause, or we can get, myectomy of the thyroid muscle or neurectomy of the peripheral branches of the recurrent laryngeal nerve, or neuromodulation with blockage of the synapses. As we go and learn what the anatomy of thyroarytenoid muscle and its function, it's the most important muscle in adduction of the vocal folds, originates from back of the thyroid prominence and inserts into the backside of the arytenoid, anterolateral surface of the arytenoid cartilage. So you can see here, this is the thyroarytenoid muscle. This is lateral cricoarytenoid and posterior cricoarytenoid. So this is the belly of thyroarytenoid muscle. Actually here you can see the bulk of the thyroarytenoid muscle, which we say a vocalis muscle. If you study the thyroarytenoid muscle, what you find, the maximum number of motor end plates are concentrated in middle 1/3 of the vocalis muscle. So this is the area where you target your thermo or chemo denervation. While doing a surgery, you target this area of the muscle. So middle 1/3, posterior 1/3, but the least of the motor end plates occupy the anterior 1/3. So leave behind the anterior 1/3 for the vocal function, which would be useful for the patient. The nerve. Thyroarytenoid nerve branch is a terminal branch of the recurrent laryngeal nerve. This is a recurrent laryngeal nerve. Travels along the anterior face of the lateral cricoarytenoid muscle. This is a lateral cricoarytenoid. It goes into the vocalis muscle in the paraglottis space and gives several branches to the thyroarytenoid muscle here. Now the thyroarytenoid nerve, when we study, it's not a single nerve which supply the whole of the muscle bundles. There are numerous nerve fibers which go along and in between the muscle bundles and supply the muscle fibers. So when we vaporize the vocalis muscle during surgery, we also see strong twitching of the muscle fibers because of vaporization or passing the thermal effect to the nerve fibers. Now, when we do transoral laser myoneurectomy, we target the end organs, that is the ventricular folds, the thyroarytenoid muscle, thyroarytenoid branch of the recurrent laryngeal nerve, the terminal nerve fibers as well, the neuromuscular junctions, but we protect the vocal ligament here, vocal ligament, the arytenoids posteriorly, and the lateral cricoarytenoid muscle. So these are the boundaries actually. So we concentrate the middle and posterior 1/3 of the muscle. We protect the vocal ligament. We go up to the perichondrium of the thyroid cartilage and posteriorly up to the vocal process of the arytenoid cartilage, and leave behind the anterior 1/3 because it has got least of the motor end plates and would be useful for remaining vocal function. When we do the surgery, we can excise the vocalis muscle as well as the ventricular bands itself. What is the advantage of excision of the ventricular bands? It has been shown that ventricular band also contain the muscle fibers and motor end plates. So it also participates, it's part of the hyperadduction of the laryngeal structures. It also gives good exposure of the thyroarytenoid muscle when you operate through a microscope. It also treats or helps in reducing the supraglottic compression as a compensatory mechanism. Let's observe this clip. So I am vaporizing the ventricular band. This is a neuropathy which I am keeping between the false and true vocal folds, just to protect the true vocal folds from accidental laser firing of the true vocal cords during the false cord surgery. So during the surgery, you have to protect the surrounding tissues. And so I'm vaporizing the ventricular band or the false vocal fold. This is a scanner mode of the laser. So it's a circular mode in which we pass the laser energy. When we remove this, we'll see the good amount of the vocalis muscle, and we are going to see in the next clip. So this is the ventricular band excision, but it has also been put forward that the ventricular bands also form the part of resonating system and aids in high notes phonation. So many authors, surgeons preferred to preserve the false vocal cord and concentrate the thermone denervation to the vocalis muscle. I have also started preserving the false vocal cords. The results are similar with excision of the ventricular bands, but of course, maybe we'll have to do a study looking into preservation of the high notes in phonation. So maybe you can preserve the ventricular bands, having a good phonatory outcome at least. So myectomy, again, as we have already seen, you do the surgery involving the posterior 2/3 up to the vocal ligament, laterally up to the thyroid cartilage, perichondrium, and vocal process posteriorly. How much volume we remove? 70 to 80% of the vocalis muscle we vaporize during the surgery, and this is gained through vaporizing 3 to 4 millimeters in depth. Many studies have been done. Is this related to the results, to the outcome? Yes, removal of muscle volume is proportional to improvement in symptoms. And of course, this is very important, duration of the relief to the patient. Again, the scanner mode, I'm vaporizing the vocalis muscle, the posterior 2/3 of it, sparing the anterior 1/3, the vocal process, going down 3 to 4 millimeters deep. Neurectomy, you can vaporize the thyroid branch of the recurrent laryngeal nerve with a curved angled forceps where it enters into the vocalized muscle, that is anterior and lateral to the vocal process, away around 3 to 4 millimeters away from the thyroid perichondrium, and deep around 3 to 4 mm again deep into the vocalis muscle. This is a curved angled forceps, vocalis muscle. I'm vaporizing the terminal branch along with the surrounding muscle fibers with the unipolar cautery. Neurectomy. So the first is vaporizing the recurrent laryngeal nerve branch, that is the thyroid branch, at its insertion into the vocalis muscle, plus, as we have already seen, it enters the muscle bundles and muscle fibers with the small nerve endings, as you have seen here. So these are the small nerve endings which supply the individual nerve fibers. So when you vaporize the muscle, like when you are doing a myectomy, it automatically becomes myoneurectomy because you are vaporizing the nerve endings also along with the muscle fibers, because the receptors are also distributed along the muscle mass and they are also vaporized during the myectomy. Myoneurectomy, in the initial periods when this procedure was being tried, our centers, amongst the first of the centers we started using this method, first few cases I tried doing unilateral because I was not aware of the risk factors and maybe the outcomes. So first few cases we operated unilaterally, and when we are sure about the outcome and minimum risk factors, then now it is an established method to do it on both the vocal folds, thyroid muscles on both the sides. Plus, it is assumed that laser weakening of the unilateral vocal fold gives abnormally asymmetric vibration of the vocal fold. Preservation of the lateral cricoarytenoid muscle prevents vocal cord palsy or paralysis also. So this is the ventricular band. Now I am preserving the ventricular band with the help of the suction or forceps, retracting it with false cord retractors also, having a good exposure, and then vaporizing the thyroid muscle with the nerve endings. What about the revision surgery? Yes, the failures or the cases which come again with the similar symptoms, you can opt for a revision surgery, which helps in the removal of the additional mass or muscle regeneration. It again adds to alienation of the symptoms. What you see post-operatively, how the wound heals. The wound over the thyroid muscle fibers heals and get replaced by fibrous or fibroareolar tissue. Significant reduction in the motor unit end plates. They weaken the contraction of remaining thyroid muscle also. So again, reduced hyperadduction, reduced spasm of the adductor muscles of the vocal fold. Muscle regeneration is also not evident, and this has got long lasting effects also. So during the first 2 or 3 weeks, as we are vaporizing thyroid muscles on both the sides, there would be some slough formation, but this edema of the vocal cords, slough formation, but this gets cleared with antibiotics, voice rest within 3 to 4 weeks, and then we can observe good vocal outcome. So this is a stroboscopy 1 month post-operatively. We are going to see the clips of the same patient in the follow-up. So this is the patient. This is the clip 3 years after the surgery. So we'll see loss of vocal strain, loss of speech breaks, and reduced tremors.
My name is I am eye surgeon doing ophthalmic practice in Surat, Gujarat. I was operated.
So we can see loss of strain, speech breaks. This is 3 years post-surgery. The same patient, 7 years post-surgery.
My age is 70 years completed and I belong to Surat. I am having Sudarshan Eye Hospital and Clinic at Laryngology, Munapani Road, Surat.
Summary of the results. We followed around 45 patients, follow-up up to 48 months. Results are moderate. We can see marked vocal improvement in all the patients after the laser surgery. Speech breaks were absent or markedly reduced. Very good results for maybe first 3 to 6 months. But all the patients persisted with reduced phonatory efforts, good or increased loudness, clarity, and improved vocal fatigue. There was no risk factor as far as the voice quality is concerned. All the patient has similar or better voice quality after the surgery. The symptom alienation with this surgery are immediate. The best possible result, the patient starts speaking well immediately after the surgery for 24 hours before the edema sets in. The results are seen up to first 3 days of the surgery when edema increases and there is a maybe start of slough formation. So it may be patients may have a heavy voice for up to 2 or 3 weeks, but then the voice settles down and patients would start getting good phonatory results. These are different papers. I mean, there are quite few papers on this subject or long-term studies. As far as thyroid and myoctomy is concerned, is Suji from Brazil. And my paper actually maybe can be compared around equal follow-up. The number of patients also, the VHS scores were quite high before the surgery and quite low before after the surgery. I think almost match the phonatory outcome using the lasers for adductor spasmodic dysphonias. What are the comparison between Botox and CO2 laser? Botox injection requires multiple sessions. It becomes costly because patient has to travel to the site, to the given location, get the injection done. This is one-off surgery, so it becomes cost effective. There is a progressive improvement with Botox injection. This laser surgery would give immediate improvement and immediate results. The main factor, short-term effects. This would give long-term effects. Approximately, we tell the patients to get 2 to 3 years of good phonation or speech after the surgery. There is an antibody development to the molecule. There is no question of any antibody because we are not using any substance. So this procedure can be repeated. There are allergic inflammatory side effects to the given or injected substance, but there are no significant procedural side effects with this procedure. The main advantage again with Botox injection can be done as an office procedure under local anesthesia. This procedure requires general anesthesia, a day's stay for 24 hours. I think thank you for your patient hearing, and we'll come back to the questions after all the talks are over. I would like to welcome you all to our second Asia Pacific Laryngology Association conference in Philippines, Manila, from December 1, 2, and 3. From December 1 to 3 in Manila. It would be jointly with the Filipino Society of Otolaryngology Head and Neck Surgery annual convention. We have got best of international faculty and faculty within Asia Pacific region and best of the scientific program. You can see you are all welcome to the conference. Thank you. You can find this on the website.
Thank you, sir, for the informative talk about the role of lasers in use of especially CO2 laser in management of spasmodic dysphonia, and giving us a wide information about the difference in CO2 laser and Botox injection in spasmodic dysphonia. Now, the next lecture is about acute and chronic laryngitis by Dr. Manjuna. Dr. Manjuna is a specialist in otolaryngology and serves as a consultant at Columbia Hospital in the state of Karnataka in India. He obtained Voice and Airway Fellowship from Denath Mangeshkar Hospital and also from the Emory University Hospital, Atlanta. He has also acquired fellowship in bronchoesophageology from University of Alabama, Atlanta, USA in 2015. He has helped many of his residents in their research works and has himself authorized various publications, presentations, and research works. Now I welcome Dr. Manjuna to talk about acute and chronic laryngitis.
Thanks, Dr. Madhav, for the kind invitation. Just share my screen. Good evening, ladies and gentlemen. At the outset, I would like to thank Dr. Gandhi and his team for extending this invitation. Today, I'll be speaking on acute and chronic laryngitis. The topic looks simple, but sometimes the diagnosis and treatment of these conditions might be quite challenging. A brief overview of these conditions. As we all know, most of the acute laryngitis is caused by viral infections that are secondary to upper respiratory tract infection. And the most common chronic laryngitis is caused by acid reflux. Acute laryngitis is typically self-limiting. It usually lasts for 3 to 7 days. If it lasts for more than 3 weeks, it's called chronic laryngitis. The importance of laryngitis lies in the fact that it causes short-term dysfunction during acute phase and secondary effects of chronic inflammation like scar formation in chronic phase. Acute laryngeal inflammation resulting in airway emergencies merit separate discussion, and there's a separate topic, I guess, as well as a chronic laryngitis caused by reflux in the coming days. So these things will not be discussed in today's lecture. Acute laryngitis refers to acute inflammation of the larynx resulting in hoarseness of voice, to aphonia, vocal fatigue, dry cough, and sometimes pain. Significant dysphonia, shortness of breath, or a frank audible stridor indicates more severe form of acute laryngeal inflammation, usually seen in it's very small children because they have a very small larynx and they mild to moderate edema compromises the airway. Most commonly seen in acute laryngitis is most commonly seen in adult population, affecting individuals in the age group 18 to 40 years of age. It's not amenable for voice therapy as its cause is usually not habitual or behavioral. Coming to the etiology, it can be divided into infectious and non-infectious causes. As you can see, the common the viruses and the bacteria that commonly affects larynx are the same ones that cause upper respiratory infections, like the rhinovirus, the strep pneumoniae, influenza, and others. Fungi, the commonest one is Candida. Among non-infectious causes, phonotrauma, GERD, environmental allergens, and inhalation of noxious fumes form majority of cases. Coming to pathophysiology of acute laryngitis, in the initial phase, we see some inflammation, congestion of the larynx. At this stage, patient may have some change of voice, minimal hoarseness, and with the inflammation comes the white cells. And with the white cells, this increases the edema of the vocal cords, and this affects the vibration, amplitude, and frequency of vocal fold dynamics. So at this stage, a patient will have definitive hoarseness of voice. And as the edema increases, the phonation threshold increases. This causes hoarseness with vocal fatigue. And as the edema increases, the patient will not be able to overcome the phonatory threshold pressure, and this results in complete aphonia. Coming to symptoms of acute laryngitis, patient will have hoarseness because the mucosal waves are affected. The mucosal edges are not straight, so there will be phonatory gaps, which results in breathiness. And since the vocal cords are bulky, edematous, voice is low pitch, and sometimes because of the inflammation, they also have throat pain. When somebody looks into the vocal cords with the conventional indirect laryngoscopic examination or 30-degree or 70-degree telescope, you can see a hyperemic and edematous vocal cords with irregular gap on phonation. If you examine on a stroboscope, then you can see that the propagation of mucosal waves is reduced. Waves show greater asymmetry and aperiodic vibrations, and there is also incomplete closure. As you can see here in the stroboscopic video, the mucosal waves are aperiodic, asymmetric, and there is also a phonatory gap. Acute viral laryngitis. The most common cause of infectious laryngitis in both adults and children, and it's caused by, like I said before, it's the ones that cause upper respiratory infections like rhinovirus, and occasionally by influenza, adenovirus, coronavirus, parainfluenza, and others. Treatment is usually supportive with anti-inflammatory medications, humidification, and hydration, and there's no role of antibiotics in these cases. Acute bacterial laryngitis, again, is associated with upper respiratory tract infection. This time it's most commonly with sinusitis. Symptoms are similar to viral laryngitis and sometimes more pronounced than viral ones, like and are associated with odynophagia, cough, facial pain, headache, apart from the usual symptoms of hoarseness. Laryngeal examinations show purulent secretions, exudative and membranous plaques within the endolarynx. Treatment is similar to acute viral laryngitis with the addition of antibiotics like augmentin or third generation cephalosporins. Acute fungal laryngitis. Many fungal species can affect larynx. However, Candida is the most common cause in acute fungal laryngitis. Although it's part of the normal oral and gastrointestinal flora, the ability of the Candida to cause mucosal infections depends on the presence of predisposing factors. The presence of defective host immunity in the form of chronic steroid use, neutropenia, radiotherapy, diabetes, etc., predisposed to a diffuse form of fungal laryngitis characterized by whitish yellow exudates, plaques, or pseudomembrane over the entire larynx extending to the hypopharynx. This is a case of uncontrolled diabetes who came to me with severe throat pain and hoarseness. On examination, you can see whitish plaques all over the larynx and started on fluconazole, and this is the picture after 1 week of therapy. Acute fungal laryngitis can present in a milder way as well with the use of corticosteroid inhalers, and this is characterized by focal thick white lesions isolated to one or both cords and the surrounding areas. As you can see here, especially with the blue light, you can see some plaques of white debris, and there is also an ulcer on the vocal cord, and this got better with the 5 days of fluconazole. Phonotrauma. Causes include abrupt and strained voice usage, persistent cough, habitual throat clearing, screaming, untrained forceful singing, etc. Due to intense friction, thermal irritation, and molecular breakdown, there is vocal fold hyperemia, submucosal hemorrhage, and edema. This is a patient who came to me with a change of voice for one day. This was after a trip with his colleagues. And you can see there's a lot of edema, there's a hemorrhage into the vocal cords, and there's a lot of mucus, thick mucus on the vocal cords, indicating avibrators, non-vibratory segments. And most of these cases are usually self-limiting and resolved with strict voice restraint modification. However, it should be noted, repetitive phonotrauma results in traumatic tissue breakdown leading to polyps, nodules, hyperkeratosis, and scar formation. Coming to supportive care, steam inhalation provides moisture for the upper airway and helps in clearing secretions and exudate. Absolute voice rest, if possible, should be advised. If not, sighing phonation is advised. Avoid whispering back because it can cause more stress on the vocal cords. Avoid antihistamines and corticosteroids because it's natural. I mean, most of patients themselves will take antihistamines because this is part of a personal tract infection. And this should be avoided because drying effect of these further increase the damage. What if you have a professional voice user, whether to cancel or perform an encouragement? If there is a vocal cord hemorrhage or exudate, then it's a strict no for performing till the vocal lesion seal. But if it is a mild laryngitis, the performer should adapt his vocal efforts during the show so as to minimize the vocal abuse. A short burst of oral steroids may be given in case of mild to moderate edema with no signs of hemorrhage or mucosal tears. This is a good, simple algorithm that can be followed if the performer has less than 24 hours before his engagement. If there is significant change in voice quality, if there is no significant change in the voice quality, then they can go for full performance. If it is yes, then evaluation under a laryngoscopy or stroboscopy. If there is vocal fold hemorrhage or a tear, then strict no non-performance. And if there is no vocal fold hemorrhage or tear, but the person still has the risk of jeopardizing his career because of suboptimal performance or by further laryngeal injury, then again no performance. But if it is not, and look for edema of the vocal cords. If there is no laryngeal edema, they can go for full performance. If there is a laryngeal edema, modified voice rest, then corticosteroids, either intramuscular or oral, and medical therapy is indicated. Coming to chronic laryngitis, the distinction between acute and chronic laryngitis is not strict, and there is considerable overlap among these. Many of the disorders discussed in acute laryngitis may also progress to become chronic. As I said earlier, reflex-related laryngitis is the most common of all causes of chronic laryngitis. Tuberculosis. This may be associated with pulmonary tuberculosis or independent of it. Purseness associated odynophagia is quite common in these cases. Lesions may be nodular, ulcerative, or exophytic. Here you can see a granulation in between in the interarytenoid region. There's a moderate ulcer on the left vocal cord, and sometimes you can see exophytic growth on the epiglottis, which is to be called as turban epiglottis. But of course, this turban epiglottis is not a pathognomonic of tuberculosis, and they can be seen in other granulomatous conditions like sarcoidosis as well. There's a chance that this could be confused with malignancy, more so if it is associated with cervical lymphadenitis and vocal fold immobility. Diagnosis is usually by histopathology, can take a biopsy of these lesions or sputum examination or dual bronchoalveolar lavage at the same time. Anti-tubercular treatment is the mainstay of treatment. Coming to sarcoidosis, laryngeal involvement is quite rare, seen in less than 1%. Laryngeal involvement is mostly supraglottic and sometimes glottic, but very rarely subglottic. Diagnosis is by histopathology, follow serology and radiology may be helpful. Treatment includes systemic steroids and surgical management of obstructing lesions within intralesion corticosteroids. This is a case of sarcoidosis. As you can see, there is a severe supraglottic narrowing. This is the epiglottis, very much deformed, almost like a turban epiglottis. Okay. This is the laryngeal inlet. It's quite narrow. So these cases do need some form of laser debridement and balloon dilatation to keep the airway open. If they don't have such obstructing lesions, then systemic steroids would do. The vocal cords seem to be pretty much normal. Rheumatoid arthritis has high laryngeal involvement, almost 25 to 30% of all cases. Dysphonia, dysphagia, throat pain, airway obstruction are common presentation. Involvement of cricoarytenoid joint with resulting ankylosis has been described. Stroboscopy may show bamboo nodes on the vocal cords. Treatment include DMARDs, or the disease-modified anti-rheumatoid drugs, and steroids for bamboo nodes. This is a stroboscopic video of rheumatoid arthritis, and you can see the left vocal cord looking like a bamboo node in between. This is paramnemonic of rheumatoid arthritis. Amyloidosis involves extracellular deposition of proteinaceous debris. Laryngeal involvement is again rare, less than 1%. Laryngoscopy shows a non-ulcerated submucous mass or a nodule with a yellowish or orange hue. Treatment of the underlying cause with resection of the masses. You can see here there's a mass, nodular mass on the left false spot with the orange hue. This clinches the diagnosis before the step back. And you can see the vocal cord is quite normal. The vocal cord on the left side was normal as well. And the patient regained the complete normal voice immediately after resection. Diagnosed granulomatosis is a small and medium basal vasculitis associated with autoantibodies against proteinase 3 and myeloperoxidase. The most common laryngeal manifestation is subglottic stenosis, which occurs in almost 20% of all affected patients. Airway obstruction results from chronic inflammation, eventual scar deposition. Airway stenosis is treated with dilatation or resection along with medical management. So this is a case of subglottic stenosis secondary to vagus, and this is after dilatation debridement. But sometimes they do need repeated dilatations. So what I do is take them in the office and keep balloon dilatation on laser debridement whenever they have some symptoms. Idiopathic ulcerative laryngitis is quite a young disease. It was first described in this century in 2002 as a prolonged ulcerative laryngitis by Swigel. It's characterized with prolonged hoarseness, and on examination, there's vocal fold ulceration, the symmetric ulcers, usually following up respiratory activation, more so with cough, and it can take months to heal. Average time to heal is around 3 months. It can range between 2 to 10 months. The criteria for diagnosis of idiopathic ulcerative laryngitis is preceding upper respiratory tract infection with cough, bilateral mid-membranous ulcerative lesions of the vocal cords, prolonged course of ulcer resolution is more than 6 weeks, and lack of response to pharmacological management. There's no acute resolution with PPIs, corticosteroids, antibiotics, or antifungals. There is a female preponderance in most of the studies, but in our series, it was a male-predominated disease. Biopsy is tempting, but it should be avoided as it can lead to scar formation. Culture of the area does not reveal any cognitive organism. As you can see, this is ulcers on both the vocal cords, and when these don't heal for some time, it's you're tempted to take a biopsy of it, which should be avoided at any cost, because this can, as I said earlier, it can lead to scar formation. So also on both the vocal cords, after severe cough, the mucosal waves are affected, and there's a phonatory gap. As the cause remains unknown, there's no consensus on treatment. A complete or modified voice rest, oral steroids, proton pump inhibitors, behavioral cough suppression are some of the commonly followed treatment regime. Permanent sequelae like vocal fold stiffness and dysphonia have shown to be common in some studies, while others show complete resolution. Thank you for your attention.
Thank you, sir, for the wonderful lecture and giving us information about the common regular every day. It was a very informative talk. Session. We got a few questions from all the viewers. Coming to the first question to Professor Marina Madbaki. I think there was already the question, Hakim. Role of re-innervation in post-thyroidectomy, external laryngeal nerve palsy with aspiration to clear liquids.
Can you repeat the question because I didn't get it? The last was
Role of re-innervation in post-thyroidectomy cases with injury to external laryngeal nerve palsy with aspiration to clear liquids.
Okay, thank you for the question. I have not done any re-innervation for the external branch of the superior laryngeal nerve. Okay, in the literature, people have done cricothyroid to cricothyroid re-innervation. The main aim is to get back the pitch of the voice because the cricothyroid function is to lengthen and enable the patient to produce high-pitched voice. Okay. So in patients who have aspiration, by re-innervating the external branch of the superior laryngeal nerve, I think wouldn't help that much because it is mainly motor nerve. The one that reduce sensation at the supraglottis region that increase the chance of the patient having aspiration is the internal branch of the superior laryngeal nerve. So the answer to that question, there is no recommendation on the re-innervation of the external branch of the superior laryngeal nerve, but people have describe cricothyroid re-innervation by putting a cable graft between the two cricothyroid muscle to increase the pitch of someone's voice. You know, those patients who have external branch injury, they have monotonous husky voice because they cannot increase the pitch. They cannot lengthen the vocal cord. So that is my answer. There are some papers describing targeted re-innervation or selective re-innervation in patients who are undergoing excision of vagus nerve schwannoma or vagal paraganglioma. You know, vagus nerve, whenever we removed, depending the level, normally whenever we excise the vagus nerve tumor, the superior laryngeal nerve will be affected as well as the recurrent laryngeal nerve. So what is described in this paper, to get back the sensation, to return the sensation of the supraglottis region, the superior laryngeal nerve, instead of just the external branch, but the whole superior laryngeal nerve, is re-innervated or repaired with the great auricular nerve. This is because great auricular nerve is a sensory nerve, not a motor nerve. So to get back the sensation of the supraglottic region, the distal part of the superior laryngeal nerve is repaired together with the great auricular nerve. And to get back the pitch at the same sitting, they did cricothyroid to cricothyroid re-innervation using a cable graft, and ansa cervicalis to recurrent laryngeal nerve for the position and tone of the vocal cord glottis level for phonation.
Thank you, ma'am. Happy to share this information that we have more than 3,500 delegates registered for this talks. And we have more than 1,000 people watching it live from more than 50 countries worldwide.
It's great.
Next,
Madhav,
sir.
Marina, just to make a few points about aspiration in vocal cord palsy. Usually what we have seen is aspiration usually is either compensated or it is get over in around 3 months in young patients. In old patient, it may take some time, but may require swallowing therapy. So basically the compensatory mechanism and sensory system maybe gets back to its normal function. It recovers very well within 3 months in young patients. So what really we need is a correction of the phonation, and that's how the re-innervation may help in that. So aspiration is usually taken care of by either the compensatory or sensory recovery. What improves re-innervation is the phonation.
Thank you, Dr. Sachin. That is a great input. I just want to add to that. Sensation is very important part for the aspiration. As you said, the patient will overcome it with compensation. And in my experience, those patients who have hoarseness and can't tolerate fluid immediately after thyroidectomy, for example, the injury was not identified during the surgery. Some patients, they have signal, very good signal, even though, cases where they use nerve monitor. So the signals are good, but unfortunately, when the patient wake up, they have hoarseness and they have aspiration on fluid. So I normally give injection on day 2 and day 3 after thyroidectomy under general anesthesia, just so much so that the patient wouldn't have to go home with nasogastric feeding. So that's something that we can offer to the patient. However, like you said, if you don't do anything, the patient may require nasogastric feeding up to 2 months while waiting for the compensation and waiting for the sensation to return for them to not to have aspiration anymore.
Thank you, ma'am. There's one more question to you. What is the long-term result of re-innervation after years?
The long-term outcome.
Long-term, yeah, long-term outcome.
Yeah, thank you so much. There are papers been published on long-term outcome. The results are good. In successful cases, the voice outcomes are stable. Because in the principle is when the surgery is successful, the innervation is returned. So then in long term, there wouldn't be any deterioration of voice. Unlike if we do a static procedure, for example, type 1 thyroplasty, initially the voice is good, but in cases where there is ongoing progressive denervation, with time, the voice may deteriorate and the patient may have to undergo a second procedure or revision procedure, and some patients may have to undergo a touch-up procedure. So in my experience in re-innervation, as well as what been published in the literature, those successful cases, the voices are stable even after 2-3 years after surgery. So I hope that answered the question.
Thank you, ma'am. Yeah. The next question is to Dr. Manjuna. Do you have any experience with nodular fibromatosis of vocal cords and how to treat this condition? Dr. Manjuna.
Hello.
Yeah, Manjuna.
One question. Do you have any experience with?
Hello.
Yes, sir. Sir, can you hear?
Yeah.
Yeah. There's one question. Do you have any experience with nodular fibromatosis of vocal cords and how to treat this condition?
Have any experience with that?
Yeah. Okay.
And sir?
Nodular, yeah. Maybe I will have to find it out. Yeah.
Okay. So, Manjuna, sir, there's one more question. In cases of laryngopharyngeal reflex or acute laryngitis, as we have said, we have to give anti-reflex. Is there any specific time duration or how many weeks or months the dosage of the proton pump inhibitors or the anti-reflex? Any specific schedule?
Sorry, for which condition?
For laryngopharyngeal reflex or acute laryngitis, as you said, we need to give anti-reflex medications. Is there any specific time duration for how many weeks or months?
Usually I give it for 3 months.
Okay, sir. And as in BD dose or OD, saying once daily or twice daily?
Start with BD dose for 1 to 2 weeks, depending on the symptoms, and then OD dose for the rest of the period.
Okay, thank you. Sir, question to Dr. Sachin Gandhi, sir. So what are the complications of thyroid myoneurectomy? And Botox injections better tolerated? And when would you recommend transitioning to thyroid myoneurectomy for a patient over Botox?
Yeah, there are two, complications. As we are vaporizing the vocalis muscle, there could be fibrosis, and then there could be a resultant phonatory gap because of the age of the vocal cord getting retracted because of the fibrosis into the vocalis muscle. So patient can have hoarseness after the surgery, but really I have not seen any of these cases. There could be vocal cord paralysis after the surgery. That also I have not seen, because then we prefer not to go into the lateral cricoarytenoid muscle. But yes, phonatory gap because of fibrosis into the vocalis muscle and retraction of the edge of the vocal cord, that could occur. But again, I have not seen, but that's the complication which has been documented using this method. Apart from these two, really I have not seen or noted any complication after this surgery. Number two, shifting from Botox to this procedure. When we started using this procedure for refractory adductor spasmodic dysphonias, the indication we started with was Botox failures, like 3 or 4 injections, and then because of the antibody development, or maybe a narrow improvement, maybe for weeks or 2 or 3 weeks, repeated injection every 2 or 3 months, that we can term as Botox failures. Then they can shift to this procedure, that is laser myoneurectomy. But over the years, as we have seen long-term results with this procedure and minimum of the side effects, we have shifted to offer this procedure as a primary procedure for adductor spasmodic dysphonia. But anybody who is really responding well to Botox, you really can continue Botox with that patient.
Thank you, sir. So there's one more question. I want to know about the advanced treatments of spasmodic dysphonia.
I think these are the methods now being tried world over. The laser surgery, there is improvement. I mean, Ishiki also has developed Thyroplasty too for spasmodic dysphonia with the new processes. Apart from that, Marina, if you have anything, I mean, the radical procedure would be like resecting the recurrent laryngeal nerve, but that would give result in vocal cord paralysis.
I think if we can add what Dr. Sachin has said about resecting the recurrent laryngeal nerve, I think that is they have done some improvement with the technique of operation. Previously, they just resect the recurrent laryngeal nerve, but then they found that the symptom recur. This is because recurrent laryngeal nerve has propensity of regeneration. If the nerve is very close to each other, it regenerates easily. So that's why the symptom recur. So if you see the literature, they have modified the surgery, and they have instead of just resecting the recurrent nerve, the surgery is called selective denervation and re-innervation of the adductor muscle. The nerve, the recurrent laryngeal nerve that is transected is selectively the adductor branch of the recurrent laryngeal nerve, and then the distal part of the recurrent laryngeal nerve is re-innervated with ansa cervicalis, so that it maintained the tone, but it really cut off the impulse of the original nerve, that would prevent from recurrence of symptoms. So, so the name of the surgery is selective denervation and re-innervation of the adductor muscle.
Yeah, this
Thank you,
also
sir.
can be, yeah.
So we have a few questions I think we'll be taking up in subsequent lectures. We have questions on palatal aberrator palsies, pediatric voice disorders, and questions on swallowing. I think we have lectures coming on the next few topics. We'll be covering about all these pediatric voice disorders and airway disorders, and also about abductor vocal cord, bilateral vocal cord palsies.
Yeah, just to add about the nodal fibromatosis of the larynx. Usually, this can be taken care of with excision, the local excision. And there is one of the case which could be aggressive. I think excision, like we do it for amyloidosis, as Manjuna has already talked about, excision and follow-up. Apart from that, there are hardly any refractory cases known in this nodal fibromatosis. These are benign things. I think I would like to thank, and before I will hand it over to Madhav, you can visit our website voicelaser.com to check for an hands-on course which is accredited by Royal College of Surgeons of England in September. It will be in all three subspecialties, that is voice, airway, and swallowing. So 3 days hands-on course. You will find the details on our website. Yeah, please, Madhav.
So thank you one and all. Thank you, Professor Marina, Dr. Manjuna sir, and Sachin Gandhi sir.
Yeah.
And also I would like to thank Dr. Vyas Prasad for sharing his video and sharing your valuable information and experience in your respective topics.
Yeah, Madhav,
So,
Madhav, yeah, there is one more thing. Some people have come up with the knowing about EMG and Botox.
yes.
So I just want to seeing the good response and the feedbacks of this laryngology series. We have really listed all the broad specialties in airway, voice, and swallowing in this, I think, 9 sessions. What we propose is to take over this in the next year and go into maybe basic topics like anatomy, physiology, imaging, EMG, and maybe all these things. We already are conducting this in our fellowship programs, but this is seems to be developing a good platform to interact with the colleagues all over this region in India and surrounding countries and all over the world. So I also maybe with Manjunath, with Marina, and all my friends will take forward this initiative and cover all these topics, maybe sub topics in the specialty, and really go on with this interaction for next year also. Thank you.
Yes, sir, that's a very great initiative. I think it will be very useful for all the upcoming laryngologists and also the trainees, the postgraduates in ENT who can get to learn about the basics of the laryngology. And for everyone, the previous talks which we had on 19 March and 16th April are available on www.voicelaser.com. So we would be meeting again on 16th of next month. So I thank one and all for joining this session. Thank you.
Thank you, everyone.
Thank you, Marina. Thank you. We'll see you, hear you soon.
Soon. Yep.
Yeah, thank you.
Thank you. Thank you, sir.
Thank you, Manjunath. Thank you,
Thank you.
Manjunath. Thank you.
Bye-bye.
Bye. Bye.